Hi everyone. We're letting you all in and we're getting you recording permissions. Just bear with us for just a moment. Should be able to record in just a minute. All right, we will go ahead and get started. If you don't have recording permissions, just let us know in the chat and we'll work to get you those quickly. Good afternoon, everybody, and thanks for joining. Today we have Dr. David Kimberlin, co-director of the UAB and Children's of Alabama Division of Pediatric Infectious Diseases. He'll be discussing the FDA approval of the Pfizer COVID-19 vaccine and more related to pediatric cases that he's seeing. We will be recording this and we'll distribute this shortly following. If you have questions, please submit them through the chat or use the raise hand function on Zoom. To get us started, Dr. Kimberlin has a couple of opening comments. Dr. Kimberlin.
Good afternoon, everybody, and thank you for being with us today. I do think we have some really positive news to report, and given how very dark things are for Alabama right now, really, I would say the whole entirety of the South, we need some good news, and so this one is a more uplifting kind of set of information to pass along. And that's what has already been stated today with an earlier press conference and then also, I'm sure, with y'all's own news releases. The U.S. Food and Drug Administration has, as of today, approved the Pfizer vaccine, the Pfizer mRNA COVID vaccine, for use in people 16 years of age and older. And that is a really positive development. And it's one that I hope will have some importance to at least a portion of, I hope a large portion of those people who have up until now not elected to receive the vaccine. This full approval by the FDA is an even stronger affirmation of what we've known from the time these vaccines were authorized, starting very late 2020 and into 2021. And that's that they do a phenomenal job preventing severe disease, preventing hospitalizations, preventing deaths. The data we had the longest or the farthest amount of time to follow on was for Pfizer, and I guess Moderna as well, but for Pfizer, 16 years of age and older. And that's why the authorization was moved to an approval for that age group, for the 16 years of age and over. It remains authorized, that vaccine does, for pediatric adolescent patients 12 years of age through 15 years of age. But it is not yet authorized for use in children under 12 years of age, which brings me to a very strong cautionary statement I want to make. And that is this newly approved formulation of the mRNA vaccine that Pfizer makes, approved for 16 years and older, should not be administered to patients under 12 years of age. It should not be done off-label. And the reason is as follows. The dose of the Pfizer vaccine that is being studied in 5 through 11-year-olds is 1/3 of the dose that is now in the approved 16 and over formulation of the vaccine. And for those children under 5 years of age, 6 months of age through 4 years of age, the dose that is being studied is 1/10 of the dose that is now in the approved Pfizer vaccine. So we cannot simply draw up less of this and give it to these younger children. We need to do it the right way, just like we did it the right way for the adults and then the adolescents and then the younger adolescents. And that means we've got to finish the studies or the companies have to finish the studies that they are conducting. They have to submit the information, all the data to the Food and Drug Administration that then reviews all of those data and looks for immunogenicity and safety, and then hopefully authorizes use of those different formulations of the COVID Pfizer vaccine for those younger age groups. That's yet to be determined, obviously, because that's out in the future. So with that, I'm going to stop. I'm happy to take any questions that you may have.
All right, thank you, Dr. Kimberlin. While we're waiting for media questions to be submitted here, one question that was previously submitted, can you address concerns from people and parents saying that these vaccine studies were rushed?
Certainly, we've heard that sentiment now for many, many months. And the simple way to answer it is they were not rushed. I've done clinical research for 27 years now, I guess. And so I write my own protocols. They're NIH funded. Then we implement them. We follow the whole process through to completion of the study and so on. And so what I've seen and learned over those periods of time is that the process of starting and running a study has inherent downtime to it. And the downtime is when committees look at the information, or it goes into a queue, a lineup to wait to get to the first on that list or on that queue for them to then be able to consider the next thing to be considered or implemented with a protocol revision or whatever it may be. There's a lot of downtime, in other words, in the overall process of thinking about what the protocol should look like to implementing and running the protocol and getting it all the way to completion. And all that was done with last year, the Operation Warp Speed that was led by the Trump administration, what was done there is that those time intervals, the downtime was shortened. And so all the components were the exact same. They just had less filler time in between, and that truncated or shortened everything down to a much more rapid kind of process. And I would suggest that was a very good thing. We're in the middle of a pandemic. We've had 630,000 plus Americans die. I think we all wanted things to go faster, not slower. So it's a good question. Nothing was shortchanged. Nothing was left out. It was just that interval period of time that was shortened down so that the overall start to finish could be shorter as well. And again, that's what we would need and would want in this kind of an emergent situation.
Great, thank you. Next question is from Chastity Maxey with Fox 6. Chastity, go ahead.
Thanks, Adam, and thank you, Dr. Kimberlin, for doing this today. So I have two questions kind of related to each other. Can you talk about what does it actually mean for a vaccine to have full FDA approval? And can you clarify again, is that for 12 years and older, or is that for 16 years and older?
The Pfizer approval that was issued today is for 16 years of age and older. The process is, as you would expect and as you would want, very laborious, very detailed, very in-depth when FDA is looking at a vaccine or a drug of some kind to approve and to put out there in front of the American public as a marketable product. And so that's what indeed was done with the data set that Pfizer submitted a number of months ago for what had been previously an authorized vaccine to then receive the approval that came through today. Now, perhaps a tangent to the question you just asked is sort of what's involved with an authorization of a vaccine. And really, it's very, very similar. The only significant difference that I'm aware of is that the follow-up period of time that is evaluated, assessed by the Food and Drug Administration when a product, a vaccine, is authorized is a little bit shorter than the duration of follow-up time that is followed by the Food and Drug Administration when they're looking as to whether the vaccine in this case should be approved. And so that it was more the follow-up to those subjects, those patients that were on the original study back in 2020 to continue to watch and see how they did following the vaccination that led to the ability to fully approve it today.
Okay, so there's probably no way to know when exactly it will be fully approved for those who are 12 years and older. So does that mean that they're still under emergency use authorization for those 12-year-olds?
For the 12 through 15-year age group, that's correct. They are still, they still can and should receive the Pfizer COVID vaccine, but for the 12 through 15-year-olds, it's under emergency use authorization, whereas for the 16 and over, now as of today, it's as a fully approved product.
Thank you for the clarification.
Thank you. Next, we'll go with Alex. I'm sorry, I'm not familiar with your affiliation. You can go ahead and ask your question.
All right, I'm with Wade 31. Just a quick question. I mean, obviously the Delta variant is something that we really haven't seen since the start of this pandemic. We've seen more kids being getting sick, more younger people getting sick. Talk about the threat of the Delta variant and the difference in symptoms you might see when you test someone who's been vaccinated versus someone who hasn't been vaccinated.
This Delta variant, as your question, suggests, it's a different kind of virus than not literally. I mean, it's still the coronavirus, but it is mutated in such a way, evolved in such a way that it spreads exceptionally easily from one person to the next. And at least in part, the reason for that is when someone gets infected with the Delta variant of COVID, the amount of the virus in that person's nose is 1,000 times higher, 1,000 times higher than it had been if that person had been infected with the original strain of the coronavirus last year, for example. So it very rapidly increases in the nose, and most likely that's what leads to at least contributes, if not completely leads to the ability of that particular Delta variant of the virus to spread between people so rapidly and so efficiently. The only virus we know of that's more efficiently spread between people than the Delta variant of the SARS-CoV-2 virus is measles, and measles is like a heat-seeking missile in terms of finding people who are still unvaccinated or uninfected. So Delta is a very concerning move or turn of events for us, no question about that. And I think we're seeing that across our state. We're seeing it in our pediatric hospitalizations now. As you know, Alabama is #1 in the country in the rate of pediatric hospitalizations due to COVID. #1 in the country in pediatric hospitalizations. We are in a very, very, very difficult place right now. And I have some serious concerns about what these next weeks hold for all of us. And that includes the pediatric side, but I would also expand that and extend it out to the adult side as well. So the Delta variant is quite a bit different. Now, what we don't yet know, and there's a lot we don't yet know as well. We don't yet know whether or not a given patient, a given child, in this example, who's infected with Delta is more likely to have severe disease than if they had been infected with an earlier version of the COVID virus. We do know, though, that the number of patients that are pediatric patients and adult too, but pediatric patients that are coming in to our hospitals is much higher than it was with the earlier versions of the virus. And so that could be because it's just so much more easily spread, and therefore it's the same percentage that are going to get really sick, but the overall numbers are bigger, and so the overall numbers that are really sick are bigger. It could be because the virus itself is more aggressive as well. I would suggest that really doesn't matter. We're left with the same reality, and that is that way too many children are seriously sick from this. Now, that's the challenging side. The good news is we now have for 16 and 17-year-old adolescents, the Pfizer vaccine that is approved for use. We now have continue to have the 12 through 15-year age group where the Pfizer vaccine is authorized for use. So we can get vaccine into adolescents' arms, and we need to do that, as well as all of their family members and the school teachers and so on and so forth. Everyone who's 12 and over who's not yet vaccinated needs to get vaccinated. And then number two is we need to wear masks, and we need to wear masks inside. And that's whether you're vaccinated or not, because someone who is vaccinated can still get the Delta variant. They're going to be a whole lot less likely to be sick, and to certainly have a whole lot less likely to be severely sick or to be at risk of dying. But they can still have a lot of it in their nose, and therefore they probably can transmit it to others as well. So that's why we all have to mask, because we don't know who is symptomatically infected or asymptomatically infected at this particular moment in time.
Thank you. Next question comes from Cassie with WBRC. It's a two-parter. Can you talk about the risk of exposure to babies and newborns? Should they be in public? How is it affecting them? And then secondly, are children treated with monoclonal antibodies?
I'll take the second one first. The authorization for the monoclonal antibodies, the COVID antibodies, the Regeneron antibodies that you've heard so much about, that authorization does extend for 12 years of age and up. So people with the risk factors who are 12 and over can receive the Regeneron monoclonal antibodies. Under 12, it's only in research settings where they can have access to that. Now, the first question, remind me again, was?
Yes. Can you talk about, excuse me, how COVID is affecting babies and newborns and the risk they have being in public?
Generally speaking, the premise coming into, or the understanding coming into this new period of the pandemic, the Delta period of the pandemic, if you will, the premise or the understanding was that younger children, and especially toddlers and younger than, infants and toddlers, were a lot less likely to be sick. And that may still hold true. That said, we have neonates in the intensive care unit and on the general wards of Children's of Alabama, or have over these last couple of weeks. And so it is possible that they can be sick enough to need to come into the hospital because of the symptoms that they're having. So I wish I had a number to give to say that a baby is X percent likely to have severe COVID or need to be hospitalized. We don't yet know that information. I think over time we will, but we haven't had enough experience, enough time period yet since this Delta variant came on so strong starting in May and then really accelerating through June to be able to know to answer that question. Now, here's what we do know, though. We know that the COVID vaccines are safe and highly effective in pregnant women. And we have had a number of newly delivered women who have died from their COVID disease, and their babies are going home with their dads, or maybe even dad has died as well, and they're going home as an orphan. So number one, moms should receive the COVID vaccine during pregnancy if they're not previously vaccinated. That's for their own health, but it's also for the health of their babies in two different ways. Women who are infected with COVID disease are more likely to deliver a premature baby. That's been shown throughout this pandemic. And if the baby is born prematurely, even if that baby does not develop COVID themselves, they still have all of the problems that a premature baby can have. And you do not want that to happen. I mean, every pregnant woman knows you want to make it all the way to 37, 38 weeks, 40 weeks of gestation before you deliver. So that's number one. You can avoid the prematurity because you're avoiding the mom getting COVID because the mom's getting vaccinated and the vaccine prevents her from getting COVID. And then the other thing that we know is that women who are vaccinated, well, the antibody that they make against the COVID virus passes across the placenta and tanks up the fetus so that when the baby is born, the baby herself or himself also has antibody. In this case, it's mom's antibody to be able to fight off the COVID virus if they are exposed. And those same antibodies are in mother's breast milk. And so a woman who is vaccinated during pregnancy or was vaccinated before pregnancy and who breastfeeds is really maximally impacting the health of her child in a positive way and protecting that child as much as possible. Now, in terms of the public going out in public, I got to say this, it's frustrating for all of us the way we've had to kind of dial it back. We had that taste, if you will, of freedom in June and moving into July, and we don't have that anymore. It saddens me that that's the case. It is the reality, and we've got to deal with reality here. And so I think, as would be the situation with any newborn baby, you wouldn't want to take a baby under a month or two of age out in public or to Walmart if you can avoid it at all. And I really would try to avoid that as well during this pandemic. But I say that not necessarily because it's a brand new baby, more just that's kind of in the face of COVID, but more because that's just kind of what we want to do anyway. We want to limit the kind of exposures that newborns will have to people who might have an infection that they could acquire.
Thank you. Next question. The first phase of this pandemic, we thought kids were pretty immune. There wasn't a lot of cases in children. Why are kids such a focus and concern now?
I think I'm going to answer that with a couple of things. Number one, it's because of the numbers. The likelihood and the likelihood of and the severity of children getting disease from COVID is simply different with the Delta variant than it was with the earlier versions of the virus. Now, so the virus has changed here. That's the reason we're having this conversation and why this very good question is being posed. I will say one thing. I'm going to push back a little bit. I know the premise of, or the sentiment of the question was the perception, but we still had, 350 or so children die in the United States from COVID since the beginning of the pandemic. And that was before Delta started coming on strong. Don't have numbers yet for the Delta variant, because again, it's just been the last month or two, and it takes a while for those numbers to get into the system and for us to be able to analyze them. COVID was the 10th leading cause of death in children last year. So children are less likely to die than adults. There are a lot less children than adults. So the overall raw numbers might not look quite as impressive, but COVID has never been a cakewalk for children. And this Delta variant especially is something that's very, very concerning for us.
Thank you. Next question is from Kim Chandler with the AP. Do the children or teens being hospitalized with COVID typically have pre-existing conditions? And what are your thoughts on whether Delta is harder on children, or are we seeing more pediatric cases because of its contagious or more contagiousness?
Yeah, I don't know about whether the virus itself is. We definitely are seeing more severe disease and larger numbers of severe cases with Delta. That's a given. And so then the reason for that is it that it's just hyper transmissible and so many more children are getting infected, whether is that, part of what it is, or is it because of the virus itself is more aggressive, causes more severe symptoms and disease courses as some part of the virus and the mutations in the virus, or is it some combination of the two? And we don't know the answer to that yet. So that one we need to give a little bit more time and try to sort through. And then Adam, you can tell I don't do as well with these two-part questions. Give me the first part one more time.
Yes. Do the children or teens being hospitalized with COVID typically have pre-existing conditions?
About 40% of children admitted with COVID, and these are the most recent data that I've been able to see, about 40% have no pre-existing conditions. So about 60% do. So that's about half and half. So unlike, early in the pandemic where we focused so heavily on, obesity or diabetes or, asthma or whatever it may be, what we have found over more recent months is that really almost half of children don't have any of those. They are normal children playing outside, with friends or with family one day, who then get sick a little bit the next day and then end up in the hospital in the intensive care unit. So the pre-existing condition consideration is much less of a determinant when it comes to which child is going to go on and get really, really sick. It still is a determinant in terms of who might qualify for the monoclonal antibodies, though, because those are in, they're not, I wouldn't say short supply, but they're not unlimited in terms of their supply. So we want to prioritize who might be a little bit more likely to get sick accordingly.
All right. I think we'll do one last call for questions. We have a hard stop at 2:30. All right. Seeing none, I think we'll go ahead and wrap it up there. Dr. Kimberlin, thank you so much for your time, and we will provide a recording for this shortly after. Thanks again, and have a good evening.
Thank you all.